Now it's official. Hi, everybody. Good to see everyone here. Good to see everybody on Zoom. Thanks for everyone joining. So the first, just a little announcement. Because of the nursing school moving from Parnassus to Mission Bay, booking rooms has been, I think, a bit of an issue. So going forwards, we'll probably do the in-person component either in this room or in the Baker Auditorium, and it may alternate. So just be sure to check your calendar. So that's that. Today, very pleased to introduce our speaker, Dr. Carissa Chu. I know her as Carissa. I've never said your last name. So, I met Carissa actually at I believe at the Prostate Cancer Program retreat a few years ago when she was doing her urology residency at UCSF. I met her at the retreat in the Presidio, and I got to see her work. She was doing research in the Fang Lab about EV resistance. EV is a drug that has really revolutionized systemic therapy for bladder cancer. It targets Nectin-4, and Carissa was looking at how Nectin-4 downregulation is a mechanism of resistance for that very new therapy. She went on to do a fellowship in urologic oncology at Memorial Sloan Kettering, working in David Sollitt's lab, and I think she's continued to work on EV resistance and the molecular determinants of that. And we were very fortunate that she came back and started as a faculty in 2023. And today she's going to talk about her research program that she's been setting up in GU Onc, and particularly neoadjuvant therapies and trials in prostate cancer. Thank you.
Awesome. Thank you so much, Rohit. So it's great to be here. Thank you for joining. I'm in my first year here on faculty. I'm a urologic oncologist, so a surgeon by training. This is sort of my coming out into the prostate cancer research world. So look forward to going over, all the exciting work we've been setting up, introducing my lab to all of you, highlighting all the work we've done with the collaborators. So today I'm going to be focusing on something that is near and dear to me. It's, the role of neoadjuvant therapy in high-risk prostate cancer. I'll talk about a clinical trial that I'm very involved with, as well as highlighting a few others that are ongoing and upcoming as well. And really trying to emphasize this as an opportunity for us to do, real-time tissue analyses and, kind of preclinical work as well, to go, bench to bedside, back to the bench. So hopefully I can go over all that with you. So goals of this talk, first, I want to highlight the critical unmet need of high-risk localized prostate cancer. For me, I'm still a clinician at heart, so part of this talk is going to be fairly clinical, and we'll get into some of the science towards the end as well. Highlight a new novel targeted therapy in prostate cancer, try to define the mechanism of action with neoadjuvant trials, and explore regulation of surface targets to understand biological function and secondary resistance. So we'll start with the case. So this case is actually one of my patients, a 76-year-old male who presented with the PSA of 3.98, actually. So it was increasing more quickly. PCP did a physical exam, digital rectal exam, felt a nodule, and was referred to me. We got an MRI prostate that showed PIRADS 5, which is a very suspicious lesion at the left base of the prostate with possible seminal vesicle invasion. And so I decided to, I recommended a biopsy to him. So here's my diagram of what the transrectal ultrasound looked like, but you can see highlighted in red, that's where his dominant tumor was. And where it kind of goes outside the contour of the prostate is where I saw obvious extracapsular extension and seminal vesicle involvement. So, we did a standard biopsy, targeted the MRI lesion as well. And we found Gleason 4+3 and 7 out of 16 cores. Because of his imaging, I also biopsied the seminal vesicles, and we found 4+3 there as well. The Gleason 4 subtype was expansile cribriform. So all of this kind of alludes to a fairly high-risk pathology. I always refer these patients to see radiation oncology. So they saw radiation oncology who recommended external beam radiation with high-dose rate brachytherapy and longer-term ADT with 18 months. He decided to go for surgery, so that's what we did. We did a robotic prostatectomy with bilateral pelvic lymphadenectomy. And then I do a little sling just to help them get their continence back early. That's something Dr. Carroll taught me how to do. And he had visibly positive extracapsular disease intraoperatively. And I actually sent a frozen section along the left neurovascular bundle, and that was positive. So I went as wide as I could. Seminal vesicle was also clearly involved once it was removed, and we just went as wide as we could. So this is sort of the anatomy of the prostate here. It sits at the base of the bladder, the rectum's right behind it. On either side along the base of the prostate, that's where the neurovascular bundle is, and that's where there was gross disease intraoperatively. And that little red arrow is just showing, where that tumor was. And to give you a sense of where the seminal vesicles are, they kind of hang off the backside of the prostate. Not prostate tissue primarily, but one of the first places it could directly invade, and that was positive as well. So the final pathology was PT3B, which means seminal vesicle invasion. We did lymph node dissection. All the nodes were negative. I had a positive 3 millimeter margin. It was Gleason 3 at the margin. So he comes back to see me. We review the pathology. I say, at this point, we just sort of watch, right? We check your PSA at 6 weeks, again at 3 months. Luckily for him, it was negative, but we sort of know kind of based on his disease and what he initially presented with, that he's probably destined to recur at some point in his life. And so here's a nomogram actually developed by Memorial Sloan Kettering. It's sort of older with a lot of historical data, so we actually didn't really even use this there. You could use this. There's better molecular tests like Decipher testing, which can give you some more prognostic information. But I basically will tell you, your likelihood of needing some additional therapy at some point in your life is quite high. At 2 years, it may be 50%. At 10 years, probably almost 85%. His 15-year overall prostate cancer survival, though, is quite good. He's 76, so he's unlikely to die from his disease, but we don't actually know that, and he's very likely to need additional therapy. So for me, I find that to be not the most satisfying outcome. And the truth is we are operating on higher risk disease as well. And this is due to the success of active surveillance in low risk prostate cancer, increasingly favorable intermediate prostate cancer. And so here you have this stacked bar chart. And this is a representation of prostate cancer risk that we operate on here at UCSF. This is data presented by Peter Carroll. The blue on the bottom, the dark blue, is low risk. Green is intermediate risk. And then the aqua color on the top is high risk. And you can see that that proportion of that aqua and green color is increasing over time. And this is due to different patient selection and also potentially more delayed diagnosis with less PSA screening in primary care settings.
Do you have that
Yeah.
data in absolute numbers? Or is this a reduction? Is this a reduction?
Overall, us operating, I don't have those exact numbers. That's a really good question. I'd say our volume for prostatectomy has not changed overall. And we do find that we're operating on higher risk disease. There may be some stage migration, as we do more targeted biopsies. Sometimes we overestimate the burden of disease, and that upgrades their risk. And now with PSMA PET, that's a whole nother ball game where we're, do we operate on oligometastatic disease, for example? But it is a trend that we've observed now for a few years, and I do think it's real. Yeah, I do think it's real. So despite that, I'd say our surgical management of localized prostate cancer has not changed significantly. For high-risk disease or very high-risk disease, which we define as the clinical stage, so seminal vesicle involvement or not, Gleason score, PSA, if they've got a decent life expectancy, if they choose to do surgery, their option really is the one, which is radical prostatectomy with or without lymph node dissection. With radiation, there's a little bit more tailoring of treatment, you could argue, with length of ADT, treatment intensification with abiraterone. But where our management changes really is later on, if the PSA comes back or lymph node metastases are found at the time of surgery. So I would say, there are some opportunities to improve some treatment intensification when you have a high-risk patient. This is not a new concept. People have tried neoadjuvant therapies for many years now. So with some older hormonal agents back in the 90s, we used, flutamide back then, and maybe there was a reduction of positive margin. But, trial after trial using combination hormonal agents have largely been negative. There may be some reduction in the tumor size, pathologic complete response, potentially minimal residual disease, but we haven't really seen something practice changing that has improved biochemical free survival or prostate cancer survival. Part of that is because our endpoints for that are really late, fairly low event. So part of the question is, is this an issue of patient selection? Are we not, saturating for higher risk patients? Or is it really the activity of whatever agent we're picking in a localized disease setting? So we don't really know the answer to that, and I think it's worth discussing or speculating on. So enter this new targeted therapy. So this is AMG 509 or xaluritamig. It's a new, one of the most novel immunotherapies currently available for prostate cancer. There hasn't been a huge role for immunotherapy in prostate cancer, as many of you know. But xaluritamig or AMG 509 is a T-cell engager that binds CD3 and STEAP1 simultaneously. And here's a little picture of sort of how it works. And it came onto the scene pretty recently at the end of 2023 at ESMO, where some pretty exciting data was presented. So this is a novel targeted therapy that is now, that was used in very, very end stages. So patients who had progressed on all forms of hormonal treatment, were metastatic, castrate resistant, had chemotherapy, probably had some form of, some of these patients had had Pluvicto as well. And so very end stages, no other options, kind of an unselected patient cohort. And you can see this waterfall plot, the dramatic drop in PSA, as well as in tumor volume. And this was presented at ESMO and also published recently in January 2024 by Dr. Kevin Kelly. Here's a representative patient here with some liver metastases, and you can see over time these tumors sort of melted away. And here's the change in the PSA, and now week 28, week 20 out has a pretty sustained response to therapy. So this may be our next, exciting agent. So what is STEAP1? We don't know too much about STEAP1, which is exciting because we can learn a lot about it. It's got this 6 transmembrane domain. We know it's a surface protein. It may homodimerize or heterodimerize with the other STEAP family proteins, so 1, 2, 3, and 4. It seems to be, inversely expressed with STEAP3, which maybe goes with more, less adenocarcinoma type prostate cancers. And there may be some role for, iron or copper homeostasis. That's really what, the STEAP 2, 3, and 4 do. They seem to do some sort of ion homeostasis. There was a nice review that was published in 2022, just sort of showing what the differential role of these different STEAP family proteins might be in prostate cancer. We know it's overexpressed. And so here's another study showing some immunohistochemistry of STEAP1 in the Fred Hutch cohort of, so their live autopsy cohort. Using multiple samples from the same patient, primary lymph and lymph node metastasis. Overall, what they found was that actually STEAP1 expression in prostate cancer may be higher than PSMA. So the way I interpret this is, if you have a STEAP1 high, PSMA high, about 60% of tumors are high in both, okay? About 28 tumors are high in STEAP1, but low in PSMA. And then, almost very, very few PSMA high tumors are low in STEAP1. So overall, looks like based on their data, around 88% of tumors are STEAP1 high, and about 60 to 61% are PSMA high. We're working on testing this also in our own TMAs here, looking at localized disease as well, using a slightly different antibody, an AMG 509 biosimilar. So we'll see if we can replicate these results here as well. And this one's a little bit busier, but each column here is a different patient. Each dot represents a tumor biopsy from that patient. And you can see that the STEAP1 expression actually is very heterogeneous within the same patient at different locations, but generally quite high, generally above the threshold of 30 is where their dotted line is. So this is like all comers. So that's something that we were interested in looking at as well. Yeah. So, but it's really kind of all over the place. We don't know, is it higher in the MET? Is it higher in the primary, right? So we just sort of assume it's high. That's one of the things we'll be looking at. This is just a quick look at CBio portal that Sasha and the lab did, and found that STEAP 1, 2, and 4 kind of lumped together and seem to be more or less mutually exclusive with STEAP 3. That's this relative to alteration profile. So going back to kind of our initial question, our initial setup for this. So, for clinically localized disease, we have a few options. If it's low risk, we'll do surveillance, sometimes focal. Higher risk, intermediate high risk, we'll offer surgery or radiation. If that fails and they have a rising PSA, the option there is more radiation and hormone therapy. At the time that they evolved to develop clinical metastases, they're initially hormone sensitive. There's an array of different options these patients can receive. And ultimately, castrate resistance can emerge, at which point they'll be selected for individual therapies such as PARP inhibitors, immunotherapy if they have some mismatch repair, alteration, radium, sipuleucel T, or Pluvicto. So AMG 509 right now has been tested and shown to be very effective in that very late stage. So what we're interested in doing is bringing it earlier to these high-risk patients to see, can we improve their disease control and also learn a little bit about the science along the way. So here's a phase 1b study, which will be hopefully opening in September. I think we're going to be the first global site on that, knock on wood. Dave O in the cancer immunology program, and a really wonderful collaborator, is the PI of this. I'm sort of the sub-I as the surgeon. But it's going to be 2 cycles of this AMG 509 therapy prior to prostatectomy for newly diagnosed high-risk prostate cancers. And I'll say one of the wonderful things about being here at UCSF is that there's already pretty extensive experience with this drug in the clinic. And there is some toxicity associated with it. In the beginning, they'd have to be hospitalized for at least a day to, watch for sort of this cytokine release syndrome. And that's been kind of brought down now to a 16-hour observation after the first cycle. But the experience here with that drug in the metastatic state makes it a little bit more palatable to now try to do it in my surgical patients, essentially. The opportunity here is for tissue is great, and the time points are fairly close together. So obviously they're going to get their diagnosis. We're going to know what their Gleason score is, their tumor stage. We allow for some oligometastatic disease on PSMA PET. They'll get through 2 cycles of their systemic therapy. There's a dose escalation phase, and then there's a full dose at 1.5 milligrams concentration. And Dave will make sure they get through that treatment well. And then within 3 weeks of their last dose, they'll proceed with radical prostatectomy. And I would just do the standard surgery that I do, probably do some lymph nodes as well. And so that now gives us matched time points for pre-treatment and post-treatment tissue. And we have a number of different studies that we envision for that. So, scientific aims here. 1, capture the mechanism of the xaluritamig effect. Like, do we think this bispecific is really truly recruiting the CD3 to the STEAP1? Are we seeing those together? Is that what is actually mediating the cell killing? So we'll be able to show that in the prostatectomy tissue. We can do some biomarker work. So we can look at the initial biopsy, look at STEAP1 expression. You could do that by IHC, you could do that by RNA-seq, whatever you like to do. And then we'll look at immune infiltration pre and post. And this is an area of, strength with, Dave O and Larry Fong and a lot of the platforms that they've already developed to evaluate this. And then finally, we'll look at, in the lab, positive and negative regulators of STEAP1 expression, and how we may be able to manipulate efficacy of this drug by maybe modulating STEAP1 expression in our models. Yes?
Is this the first trial where or this bite is being given to patients that have not had any hormone therapy, and they're not getting any
Yes.
hormone therapy?
Yeah. So one of the theories is maybe there will be less toxicity because they may be hormone intact, or they're sort of earlier in their disease stage, and so they may tolerate the treatment a little bit better. But we don't know. Yeah. Yeah, good question. There was some discussion about whether or not we need to add an ADT arm to it as well. Yeah. Any other questions? Yeah, we'll look at that. Yeah, we'll look at that. How? Oh, so I think we could probably draw on some of the other studies that have been done. We'll use the fresh tissue as well, and we'll do some single-cell RNA-seq on that and just see what the actual phenotype of those T-cell receptors are and what's going on. Yeah. So I'm learning some immunology as we go. But I would say there giants before me have sort of laid this path already and done a lot of this work already. And here's an early study from Larry Fong and Eric Small, characterizing, back in 10 years ago, pre and post treatment tissue for patients that were treated with Sipuleucel T and Provenge. So Sipuleucel T we don't use as much in the clinic anymore, but it was sort of this really exciting prostate cancer vaccine that was developed, where you remove leukocytes from patients, you prime them with sort of this fusion protein, you put those cells back into the patient, and it identifies and attacks the prostate cancer cells. And there's this whole sort of apoptotic pathway that's been described. And so that is probably the earliest and first immunotherapy that we do have for prostate cancer. And what's described here is using, immunohistochemistry, looking at, untreated and treated patients, seeing how many immune cell populations are being recruited, not just to the center of the tumor, but sort of that interface between the benign tissue, so the BE here, this is the tumor interface here, and here's the actual, you can see those glands there, that's the prostate cancer there. So, you can see the CD3 cells, CD8 cells are highlighted there. CD4, FOXP3 are positive, and then here's their control here. And then the type is a little bit small, but here's biopsy, here's benign. You can see at the interface, those CD3 positive cells are found in higher numbers, and then a little bit quieter in the center, which is interesting. And then here's just another, bar chart, graphical representation of these different populations. So CD4 helper, CD4 effector, and CD8 cells. Any questions about this? All right. So planned studies. I say planned because I'm still in my first year here, so we need a little bit of time to get the tissue. Also, the trial needs to open. And so we'll do, multiplex immunohistochemistry. We're working with Will Chen, actually, is developing a very cool platform to do this. Just looking simply at is STEAP1, CD3 expression associated with treatment response. We have plans for both the, FFPE tissue and the fresh tissue. We're currently kind of negotiating right now how much fresh tissue we'll be able to get. And then hopefully some spatial as well, because as you can see from the prior study, the sort of the spatial orientation of these different populations may actually be important. This is a much more expensive endeavor of something that has previously been described very elegantly with IHC, but I think that's how things go these days. And I'm not a huge fan of heat maps. This one blurs my eyes. There's 4,000 prostate cancer samples here, but these are all localized tumors, and this is from the Decipher database. This is something that Matt Cooperberg just sort of quickly put together for us. But looked at, what is the we can use this database to look at, what is the distribution of STEAP1 expression and other potential biomarkers in high-risk cancers from the limited tumor tissue that we get from the actual clinical trial. So you can kind of, see if you can expand those smaller observations in other historical prostate cancer samples that have already been sequenced. And then looking at sort of these extreme responder phenotypes, a tumor that's really, really treatment refractory versus one that's completely melted away. How does that kind of measure up against an existing transcriptome of localized prostate cancer samples? And so, to do a little bit more work here, we worked with Mick here, who's a postdoc in Dr. Fang and Quigley's labs. And here we're looking at characterization in metastatic castrate-resistant disease. So West Coast Dream Team cohort. And this was recently published. This is published data. There's a little over 200 patients in this. Looking at the different epigenetic regulation, epigenetic differences in different subtypes of CRPC that have been described. So essentially what we found here was that, STEAP1 expression is here on the y-axis, okay? So STEAP1 expression is higher in these AR positive subtypes, okay? So AR positive, neuroendocrine negative, AR low, neuroendocrine negative, AR positive, neuroendocrine positive. So it seems to track with AR positive subtypes of prostate cancer. Whereas when you're an AR negative, whether you're neuroendocrine positive or negative, it's still a little bit lower. And this is sort of showing that again, looking at just the two broad categories. So that's one thing that we sort of described about this particular phenotype. And it was also nice to see that, as I described previously, there seems to be a strong association with sort of these copper homeostasis pathways, just as sort of a nice validation that the function that we think of for STEAP1 is actually sort of also recapitulated in two CRPC data sets. And then here's the volcano plot showing what else kind of correlates well with high STEAP1 expression. So STEAP1 and STEAP2 both are on chromosome 7, so that may be part of it. And then some of these other markers that, again, go with sort of AR positive prostate cancer. So, this remains to be explored a little bit, sort of just early work on existing data. But I think once we have some, trial correlatives, we may be able to explore this a little bit more. This is something that Sasha in the lab has been working tirelessly on for months now. But we are setting up a CRISPR screen on STEAP1 expression. Looking at a flow-based CRISPR screen, looking at what's regulating STEAP1 expression. We are testing the new version 3 of the library, which has 2 guides per gene. But the general idea of this approach is to selectively knock down each gene individually, see what renders that particular cell to have extremely high or extremely low STEAP1 expression. Do some back sequencing to figure out, okay, which genes were actually knocked out that altered STEAP1 expression. That's sort of the basis of CRISPR screening, at least when it comes to flow-based expression screens. And so in order to do that, we have to make sure we have an antibody that works for flow. That way we can really truly feel confident that when we're identifying these STEAP1 high or STEAP1 low tumors, prostate cancer cells at the end of this screen, that we're truly seeing what we think we're seeing. So that's what this experiment, these experiments sort of are catered towards. On the far left here, we have the Western blot. Sasha did this Western blot showing STEAP1 expression across these different prostate cancer cell lines. We're going to repeat this with the C42Bs as well. But expect to see sort of this higher expression, consistent with the sequencing data from the patient cohorts. And then, this sort of transient inducible expressing cell line here, the 22RV1s, we're able to show that we're able to overexpress it here. And then, using the CRISPR, sort of like the crab, so just inhibition and not cut, using that system, we're able to knock down STEAP1 pretty well by doing that. So it seems like our antibody's working. We played around with some of the timing of our stain, and we got to make sure that these cells make it alive to the end of the screen because it looks like they don't like to be fixed. So we gotta do that, and then we'll probably hopefully get our screen done in the next week or two. So, going back to, the aims of this trial and what we hope to be able to answer, we hope to capture the mechanisms of the effect of the drug, look at predictors of response, and then simultaneously look at positive and negative regulators of STEAP1 expression in prostate cancer cells. And our goal, hopefully, is to, eventually be able to use other models to look at actual drug resistance and sensitivity once we have access to it for the lab. Highlighting a few other trials that are on the horizon and in progress. So this is a similar neoadjuvant setup comparing lutetium and actinium targeting of PSMA in high-risk prostate cancers. And so here we're comparing PSMA targeted therapy with a different, alpha versus beta attached to it, and seeing how that actually is playing out in the tissue, analyzing the prostatectomy specimen at the end. This is enriched for a very high-risk cohort, so these patients have to be 4+5 with pelvic nodal metastases, and obviously a PSMA scan that shows positive disease. And they'll get, there's an intravenous and an intra-arterial arm, but they'll get either 1 dose or 2 doses of the drug and then go to prostatectomy. Our endpoint here is really dosimetry, so how much uptake of the therapeutic is seen in the prostate, and then other endpoints like pathologic response and PSA response. We do have, it's no longer going to be a randomized cohort 3, it's just going to be sort of a biospecimen arm, but comparing that obviously to untreated tumors as well. Here's one that's already opening and enrolling, and doing well. This trial is in arm C here, looking at a single dose of atezolizumab. Now we're at atezo plus toci, looking at basically immune infiltration after a little bit of immunotherapy prior to radical prostatectomy. And the idea of this is really not to delay time to surgery, but also to be able to evaluate, the effect of these agents in the tissue. Here's an interesting one looking at more imaging changes in the hyperpolarized MRI. This is looking at abiraterone and prednisone prior to radical prostatectomy, also in high-risk patients. And with the baseline, hyperpolarized MRI, another one at 4 weeks, and then another one right prior to radical prostatectomy to look at changes in imaging from baseline on therapy. And also looking at pathologic response. Other neoadjuvant trials have looked at ABI and PRED with combination therapy, and haven't shown a significant change in pathologic response, but potentially this is a higher risk cohort than what was previously looked at, so there may be some differences there. So here's sort of our current neoadjuvant trial landscape, all the different studies and who's leading them kind of like in order of risk. And so it's a really exciting time to be seeing these patients in clinic and thinking about, how we might be able to intensify their treatment prior to surgery, really with the hope of, increasing chance of disease control and cure potentially. Different endpoints being looked at. This one's already open. This one's probably opening soon. We're opening in September here, and then hopefully once we get a stable supply of the actinium, we'll be able to open the LUTAC trial too. So yeah, I think that's what I have. I really want to thank my lab team. We are small but mighty. Sasha here has been with me for almost a year now. Ariel's a medical student. She's doing 3 months with me. And then we're bringing on Tamila, who is a senior specialist, and she's going to be doing a lot of work, hopefully with some of our in vivo and in vitro models. So feel free to join us or work with us. Everything I have presented today really has been with the work of many others. I really have to thank my mentors, Felix, Peter Carroll, Ben Breyer, so many other people on this list. All my collaborators are basically mentors, pathology, Luke Gilbert, how long with their expertise in CRISPR screens. And also my funding, my department, the K-12 I'm on that just started, and then Stephen and Faith Brown as well. for their generosity. So that's it for me. I'm happy to take any questions. Looks like we have a little bit of time here.
Questions? There's a question in the chat from Donna Peel. What preclinical models are you going to use to modulate STEAP1 expression, evaluate on immunotherapy? And I think you talked about a sort of an in vitro screen for STEAP1 expression. I was wondering if maybe what is the data or models have you been thinking about doing, maybe like T-cell engager mouse studies? Or
yeah, I mean,
humanized mouse or do
I know.
a few murine models
Yeah.
they have STEAP1?
Yeah,
Not bind to that.
yeah. I think once we move into mouse models, it gets much more complex with immunotherapy. You know, I was planning just to start small and just do sort of T-cell cold culture in, you know, in our existing cell lines. That was my approach with the EV study. So I figured I'd, you know, rinse and repeat that a little bit. And maybe try a couple different cell lines. You know, the dream would be to be able to, you know, start passaging, you know, patient tissue, like these, you know, organoids from maybe post-treatment, and, you know, see if we can develop some sort of drug sensitivity assay using that. But moving into in vivo, you know, I'm not totally sure how we're going to be able to pull it off just yet. So it's something we're still thinking through. Yeah. Yeah.
One of the people I talked to at Forces about this was talking about the
Yeah.
and speculating that it could be more useful to look at with tumors that are larger
Mm-hmm.
because of the deeper.
Yeah.
Is there a metric we can do with the pathology of
Yeah, we plan to do a lot of that actually, and that's where we will rely a lot on our pathology colleagues to do. You know, we don't actually know what kind of cell death is happening, you know, at the interface, and there have been different kind of pathways that have been described, but you know, that's a very fundamental question we don't actually know, and so you know, we could probably do some, you know, spatial and sort of figure out, you know, what populations are there. We think it's, you know, probably immune mediated, but we don't actually know that. And yeah, there may be something about having a larger tumor which can, you know, maybe soak up more drug, which may be the case for, yeah, which may be the case for a lot of these neoadjuvant regimens, actually, if you think about it, because you know, there have been some very potent combination therapies that haven't quite given the pathologic outcome that we expected. So it's interesting to see how, you know, this T-cell engager actually is going to perform in localized disease too. Yeah. Based on what's been published, it seems to be quite high. Oh, in the body, where else is it expressed? So I think it's expressed in skin, if I'm not mistaken. We looked at this before. I don't have that data in front of me. One of the interesting things is that there's quite a bit of myositis, not quite a bit, but one of the unique adverse effects of the therapy is a pretty profound myositis. And so there was some thought that maybe there's some STEAP1 expression there. But I don't think that's actually been demonstrated. And we're looking at, you know, some other, you know, maybe myosin pathways that are involved.
And are there cell lines that are, you showed some that were lower, that are negative in STEAP1 that you could basically run a screen on and see if they're activated?
Yeah. 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 Yeah, we could definitely do that. And that would be interesting too, because you could see like, oh, if something is, you know, more neuroendocrine, can you induce sensitivity to the drug? Yeah.
It was a really nice talk, great to see the data, but I'm really intrigued by the correlation between C1 coming up and the signature of AR positive.
Yeah. Yeah.
I wasn't quite sure in your aims, is that something that you want to grow, because you've got some really
Yeah.
When you've got your clinical trial,
Yeah.
to see what happens with now.
Yeah.
STEAP1,
Yeah.
is there now going to be a feed forward
Yeah.
in terms of even more
Yeah.
understanding work?
Yeah.
The other is your antibody.
Sorry?
The other tool is your antibody.
Yes.
That you have.
Yep.
So, question about your antibody is, do you know if it's functional? Is it neutralizing? Is there, or is it just a binder?
I think it's just a binder.
Is there a way to
That's a great question. So I think we can sort of answer the AR regulation question with our screen. The issue is that if you have complete knockdown of AR, I think that the cells die and then they don't make it to the end of your screen, so you never know. But if you have like an incomplete knockdown, they may survive enough that you can see what happens in the end. Or we could play around with that, just, it's just a single, maybe, manipulating AR expression alone and seeing what that does to SEEP1. Yeah, it's sort of been observed. It's actually not really published anywhere, so I'm curious if it ever will be, but it's sort of observed that SEEP1 expression goes up after ADT. Doesn't make total sense in my mind, but I think clinically that's been observed, so yeah. Any other questions?
Well.
All right.
Thank you so much.
Thank you.